Chronic pain is not a substitute of professional medical advice, diagnosis, or treatment. Always seek the advice of a physician for any questions you may have regarding a medical condition. Hello and namaste. It's me, Bipana Gurung.
It's me, Achyut Marahatta.
First of all, I'd like to welcome you all to yet another episode of our podcast brought to you by Creative Callosum Nepal.
In this program, we will be discussing about various diseases which we have encountered during our clinical postings. Without further delay, let's move on to today's case scenario.
Okay, I'll read it out. A 8-year-old boy was brought to our hospital with a chief complaint of pain in right knee since last 22 hours. Pain was acute in onset, progressively increasing, throbbing in character and non-radiating in nature, and severe enough to hamper his daily activities. Pain was so severe that he was unable to move his limb. Pain was exacerbated by any sort of movement and relieved unrest. His mother also complained for fever for 12 hours, which was measured to be 101 degrees Fahrenheit. Fever was associated with chills. There was no history of trauma and sensory impairment in the affected limb. On examination, child was found to be ill-looking with rapid pulse, that is, under 20 beats per minute. There is local warmth and marked tenderness around the right knee. All movements are restricted and almost completely abolished by pain. On further examination, toenail infection of right foot was seen. So, what might be the diagnosis in this case?
I think it could be septic arthritis. Usually, septic arthritis presents with severe pain that completely abolishes the range of movement. Fever with chills and local tenderness, warm, further support the diagnosis. Most probably, it could have spread from infected toenail via hematogenous route. I also think it could be acute osteomyelitis. Its features like pain, fever, localized warmth, and tenderness were also strongly suggestive of acute hematogenous osteomyelitis. What do you think? What can be other differential diagnosis?
Based on the clinical presentation, I think it might be hemophilic bleed, rheumatic fever, juvenile rheumatic arthritis, and gout. So, what will be the next step to reach towards diagnosis?
We should order for investigation like total leukocyte count, erythrocyte sedimentation rate, and C-reactive protein level, X-ray of affected limb, and ultrasonography. TLC, ESR, and CRP are indicators of systemic infection, which not only suggest infection but also guide prognosis. If we still not diagnosed, MRI and radionuclide scan can be performed. Do you have anything to add up which I have might miss?
Yes, you have already mentioned most of the diagnostic modalities like blood investigations, X ray, and ultrasonography. However, these special investigations may take time, and it is much quicker to aspirate and examine the fluid. The joint fluid is examined for WBC count and gram stain. Here, I have the laboratory investigation report of the patient which I will read out. It goes like this. Blood investigation showed rise in total leukocyte count, ESR, and C-reactive protein. In X-ray, there is soft tissue swelling, widening of the radiographic joint space, and slight subluxation of joint. Similarly, in ultrasonography, there is widening of joint space with positively echogenic fluid.
What about the joint aspirate examination?
The synovial fluid examination showed leukocyte count of 60,000 per ml, which is highly suggestive of sepsis. On gram staining of aspirate, gram-positive cocci was found, which is most probably Staphylococcus aureus. Owing to the results of investigation, our diagnosis is more likely to be infective and inflammatory disease of joint, that is, septic arthritis. So, is this our final diagnosis?
Yes, it is. As the lesion is located in the joint, it is less likely to be osteomyelitis, which mostly involve metaphysis of long bones.
So, how can we manage a patient with septic arthritis?
Basically, septic arthritis is considered as one of the orthopedic emergencies, so we should start treatment as soon as possible to prevent the dreaded complication. We should follow four important aspects to the management. First is the supportive treatment for pain and dehydration, where we provide analgesic at repeated interval and fluid therapy for dehydration caused by septicemia and fever. Second approach is use of splinters in affected part as it provide comfort and prevent joint contracture. Third, and the most important aspect of management is proper use of antibiotics. Initially, before culture report of drainage, drug of choice is based on judgment of most likely pathogen. For neonate and infant up to 6 months of age, treatments will be effective against penicillin-resistant Staphylococcus aureus, Group B Streptococcus, and gram-negative organism. Drug of choice are flucloxacillin plus a third-generation cephalosporin like cefotaxime. For children 6 months to 6 years of age, treatment should cover against Haemophilus influenzae unless it is known for Haemophilus influenza vaccine. This is best provided by a combination of intravenous flucloxacillin and cefotaxime or cefuroxime. For older children and adults, majority in this group will have staphylococcus infection and can be started on IV flucloxacillin and fusidic acid. If our initial examination shows gram-negative organism, a third-generation cephalosporin is added. The fourth aspect of treatment is surgical drainage if necessary.
Yes, after initial management is completed, aftercare approach is also done. Here, in early stage, if articular cartilage has been preserved, then gentle and gradual increasing movements are encouraged. For late presenting cases, if articular cartilage has been destroyed, the aim is to keep the joint immobile by splinters in optimal position while ankylosis is awaited, or else joint replacement should be done. So, before closing discussion on our case, what would be possible complication of septic arthritis?
Complications are mostly seen in infants where there is subluxation and instability of joint, damage to fascia, articular cartilage erosion, ankylosis, and secondary osteoarthritis.
In this episode, we discussed about the case of septic arthritis. Thank you for listening patiently. Don't forget to like, comment, share, and subscribe. We'll be back with another episode. Until then, have a good time.